Hey everyone, and welcome to eMedical Academy's case presentation. My name is Aki, and I would like to share with you a case that I had a few years ago that I think will be very interesting for all of you. This was an elderly patient who was admitted to the hospital with small bowel obstruction and initially was in the emergency department. She was taken directly to the operating room where she underwent lysis of adhesions and partial small bowel obstruction. After surgery, she was admitted to the ICU overnight, and she was still hypotensive and received fair amount of fluids, about 6 liters of crystalloids, from 2 a.m. until 6 a.m. in the morning when I came to see her. In the morning, she was still hypotensive and tachycardic, despite all this large amount of fluids, and this was unusual. The surgical team who came to see her after surgery recommended to start inotropic support, giving the failure in fluid therapy, and this was aggressive fluid resuscitation. Nevertheless, I did not want to start inotropic support without performing an echocardiogram, which I did. And here I have the apical 5-chamber view, which provides a lot of information about the patient's hemodynamics. And just for the fun, I would like to ask you a question about this clip. If you see this clip, the apical 5-chamber view, you should expect 1. Loud systolic ejection murmur, or 2. Expect loud diastolic murmur, or you should administer more fluids, or the combination of systolic and fluids, or diastolic murmur and fluids. I'll let you stare at the clip for a moment, make a choice, and I will provide you with the answer. The answer is give fluids, but you should also expect on the physical examination loud systolic ejection murmur, and I will go over that in a minute. Let's go over the anatomy. So we start with which view is this? The apical 5-chamber view, and the 5th chamber is the LVOT, or left ventricular outflow tract, which is right here. The other chambers are the left ventricle, the right atrium, and the left atrium. Here we can see the mitral valve, and sort of you can make where the tricuspid valve is here. Actually, I don't see it, as I nicely see the mitral valve. The aortic valve is here, and you can see that overall the clip is overgained, and that's very typical in emergency situations and when you scan in a light room in emergency. What stands out, I think, is that the left ventricular walls are basically kissing each other all throughout the cardiac cycle, both in systole and in diastole. This heart is extremely underfilled, both the right and the left ventricles, probably as extreme as it gets with regard to the inability to separate of the walls in diastole, except for the apical region. So a very extreme situation of underfilled. Even though she received so much fluid, she was still under-resuscitated, as you can see here. And why do I say that you expect loud systolic ejection murmur? And the reason is because we're dealing here with a diagnosis that is called dynamic LVT obstruction. The LVOT, or left ventricular outflow tract, is this region here that connects the left ventricle with the ascending aorta, just below the aortic valve. And what stands out, at least to me at this point, is that, and actually in the care for the patient, is the bowing or the hockey stick-like appearance of the anterior mitral leaflet in systole. It may be difficult to sort of observe when the patient is tachycardic, but we can actually stop the clip and roll back. And you see here I have an ECG, which I recommend highly for all of your patients when you have a minute. I know that sometimes in the heat of the moment people forget, including myself. But if you remember, it is nice to add the ECG to your patient's echo. In any event, you can see here this is where we are on the ECG cycle, and you can see that the beginning of systole there is bowing of the anterior mitral leaflet into the LVOT. And you can see as we progress in the cardiac cycle in mid-systole, there is total obliteration, at least by 2D, of the left ventricular outflow tract. And then in diastole, the mitral leaflets open up. This is sort of the posterior leaflet and the anterior leaflet. And then in systole again, you can see very nicely here the bowing. And this is abnormal. This should not happen. Usually there's separation between the mitral valve coaptation area and the wall of the left ventricle, creating the LVOT and passage of blood out of the left ventricle, out of the heart into the body. So we can write it again, and you can see in systole, this is what happens. Let's go over this again in a larger form. You can see here very nicely the bowing of the anterior mitral leaflet. Again, systole, sort of mid-systole or peak systole, and you can see total obliteration of the left ventricular outflow tract. Obviously, this leads to gradient, and we'll go over that in a minute. In the field, at the patient bedsides, if you are having a difficulty with seeing it at normal speed, you can slow down the speed on the machine, which makes it easier to follow both the ECG and where you are and what's happening in the patient, or just stop it altogether and drag it as I showed you back and forth. So the topic of dynamic LVT obstruction is a big topic by itself. We can dedicate a whole lecture about that, which we're not going to do today, just to go over sort of the very high level points. So typically associated with cardiomyopathy. In this case, there was no cardiomyopathy, and it's relatively frequent cause of unexplained hypotension, more than what people would think or know. And you can see it in temporarily in some form of disease processes and clinical conditions such as hypovolemia, and sometimes under general anesthesia, which leads to vasodilatation. It is a dynamic phenomenon, not a fixed phenomenon, and it requires the coexistence of predisposing anatomic factors and the physiological conditions such as hypotension and general anesthesia that induce this event. And diagnosis is with the echocardiography, as we just demonstrated. Now, when you interrogate the obstruction, in this case, in our patient, we saw this we did interrogation with continuous wave Doppler, and you're interrogating the aortic valve, and you can see very high gradient between the left ventricle and the ascending aorta, as high as 102 millimeters of mercury, which is critically, it's similar to critical aortic stenosis. That's the analogy. And you can see very characteristic of dynamic obstruction. It's a dagger shape spectral display. And at the beginning of systole, the gradient is sort of on a low side. And as systole peaks or progresses, you can see that the obstruction peaks and then resolves towards diastole. This is a characteristic spectral display of dynamic obstruction as opposed to fixed obstruction. You can see here, just for the sake of demonstration, this is a spectral display of aortic stenosis, and you can see a symmetrical shape as opposed to dagger shape in dynamic obstruction. Again, aortic stenosis, fixed lesion, dynamic lesion. Just of note, the flow that you can see here, the highest or peak flow, is flow that is seen or interrogated from the smallest orifice, so the aortic stenosis, and this is flow from the LVOT. So you can see lower flows across the LVOT and higher flow in the across the aortic valve, which is stenotic. In any event, both of them are very high peak gradient between the left ventricle and the ascending aorta, and the management is basically the same, very similar to aortic stenosis. You want to maintain preload, maintain afterload, so a patient should receive large amount of fluids. Afterload increase. Typically, we use phenylephrine for that, alpha agonist, which squeezes the arteries and help with afterload increase. Ideally, you want to avoid tachycardia and even use beta blocker to increase inflow and filling time of the left ventricle as much as possible. Sometimes patients do not tolerate beta blocker, obviously, in these situations. And ideally, you want to maintain sinus rhythm, which is useful for LV filling as opposed to rapid AFib, which actually can aggravate the situation. So this is what we did. We placed the patient on phenylephrine drip, and this is the clip that we saw 24 hours. Nice thing about echo, you can use that as a monitor. Even though it's a spot monitor, it's a very useful monitor. And you can see here 24 hours, the left ventricle is slightly more full than the day before. Still hyperdynamic. You can still see the dynamic obstruction here. I can stop it again and go back and forth and show you. And again, maybe not as high quality as a clip before, but you can see that there is in systole bowing of the anterior mitral leaflet. And this is the day after on phenylephrine. Although the clip on 2D looks very similar hyperdynamic, maybe slightly less from baseline, the gradient decreased from over 100 millimeters of mercury to 21 or so. And I was lucky enough to catch the nurse give 5 milligrams of Lopressor that we had decided to give the patient. And you can see that the gradient even further reduced. So this was very cool demonstration of physiology with echo at the bedside, which was very rewarding. The outcome was good here. The patient got extubated the next day, and when talking to her, she had reported that she was having systolic ejection murmur all throughout her life. And the etiology is unknown. She didn't have any prior echoes, and we didn't have any echoes to compare to. And she did well overall. As far as future management of this particular patient, I cannot tell you what the guidelines will tell, whether she needs to have any intervention to reduce that. We instructed her to avoid situation of dehydration, and we referred her to the cardiologist for further workup and follow up. And I do not know what the outcome of that, but we did refer her to a cardiologist when she was discharged home. And so I would like to thank you for listening and observing this nice case. I hope that you liked it, and I hope that you will continue to follow us and provide us with feedback. It'd be great. Thank you so much.